Welcome to the final installment of our three-part series. Let's wrap things up with another great conversation. Let's change topic a little bit. Anti-nuclear antibody. You've recently spoken out about ANA tests. A positive ANA test doesn't automatically mean that you've got an autoimmune disease, yet they are the number one reason patients get referred to rheumatologists, I understand. Can you tell us a bit more about this misconception and how patients can better understand their results? And frankly, how can doctors like me, for whom it's not their specialty, how can we understand it?
Well, okay, so ah, I'm gonna be so the I think the reason that we cannot see a rheumatologist right now within a 3 month, unless you go in the direct care model, um, is that we have a lot of consultation that shouldn't be. And the number one consultation is a positive ANA. The issue is that sometimes because we don't like physician and APPs, advanced practitioners do not have the time or do not understand necessarily. They're gonna kind of order a ANA on anyone. You can like there shouldn't be an ANA if like we should not do a testing if we don't know exactly what we're looking for, right? So it cannot just be, oh, you have fatigue, let me check an ANA. Like you have fatigue, what is going on, right? Like you have fatigue, what is your sleep looking like? Do you have any joint pain? Like, right? Like it's like, if I'm going to order an ANA, I have all of those ideas. Like, do you have joint pain? Do you have a rash? Like a skin rash? Do you have any changes in urine? There has to be a reason why we check that ANA. But right now, that's not the case. Right now, I think there are some testing that people love to do where there's going to be an ANA. And the ANA is going to come up and it might be positive. And then there's two different type of looking at the ANA. There's a direct with ELISA. It's very cheap for the lab that does that. The problem is that it doesn't tell us the full picture. It doesn't tell us how the ANA is, and it doesn't like it tells us a number, but it doesn't really like it's not a very good test. And then the one that we like rheumatologists is the with immunofluorescence that tells us the pattern of the ANA. And that by itself actually gives us a lot of information. And the titer also gives us information. And what we have to realize is that an ANA by itself that's positive doesn't mean an autoimmune disorder. And on the other side is you can have an autoimmune disorder and have a negative ANA. That is absolutely possible. So that's like the other thing, right? So I created this website, positiveana.com, because I realized that there's a lot of people who don't know what that means to have a positive ANA. And so the website is like if you go to positiveana.com, you see, all right, this is what an ANA does. This is how we approach a positive ANA, because that takes, a little bit of time to explain, but this is what we approach in a nutshell is we listen to you, we examine you, and we make sure that there's no autoimmune processes going on, and then we can complete the autoimmune workup in a nutshell. And then again, there's a full video of how to do this on positiveana.com. And then the ANA, a positive ANA can be associated with different diseases. It can be associated with infection. So HIV, Hep C, syphilis can cause a positive ANA, but it also can be associated with cancer. It can be associated with nothing. It can just be like that. It can be like something that we have. Um, it can precede an autoimmune disorder, or it can be with an autoimmune disorder. And I think that that's what I was trying to do in this positiveana.com website, is to basically take away the stress of patients so that they can learn. And I'm interviewing different specialists in their field. So Sjogren specialist, scleroderma specialist, dermatomyositis specialist, JIA specialist, infertility specialist. And as we go, I'll have more specialists talk about positive ANA and their conditions. And the idea also was for physician or advanced practitioners who suddenly have to deal with this positive ANA to have a website to share with patients so that they can educate themselves. And they, it's a long conversation. Positive NA is actually not a short conversation. So
That's
yeah.
fascinating. We'll definitely put a link in the show notes to this. I mean, well, actually, it's a nice segue. You mentioned twice now syphilis. I during finals, medical school finals, back in the day, there was a patient doing the rounds who had Charcot joints, disordered joints from syphilis, and fascinating to see and examine this patient and see the X-rays. Subsequently, I've never seen a patient with syphilis. To tell us that story, and maybe a maybe a recent patient success story that deeply moved you.
Yeah. So there is an uptick of syphilis in Colorado. So it's actually a very funny story in a way. Uh, Maybe a week before, I remember joking with my friends at the climbing gym, and I was like, "Well, women have 380% increased rate of syphilis right now, guys." And I was just joking. I was like, "Make sure you're using condom." My friends are much younger than me; they can be wild, and I was like, "Make sure you use a condom, right?" And didn't think of it. I mean, the free 80% increase, it might be like from 1% to 5%. Like it's not like,
Yeah.
it depends on where you're coming from, right? I haven't made a diagnosis of syphilis. I don't think I've ever made a diagnosis of syphilis until this year, right? And wasn't necessarily on my radar, just as a okay, well, there are some people who some patients who have some risky behavior. And I think when the HIV pandemic was deadly, people were much more likely to put a condom, whereas now people are more lenient, they can use PrEP and so on. So that's another conversation, which is another success of medicine, right? uh, and I basically had a patient with skin rash and joint pain that was very inflammatory, very severe joint pain. And he came to me on high dose of prednisone. And normally at that high dose of prednisone, you don't have joint pain. And it just normally at the end of my hour, I know what's going on. Like I have a very good sense of what's going on. And then after it starts, I start thinking. But anyway, he had had skin biopsy of those rashes, and they were no, they had not said anything. And basically, I sent him to another. So I didn't really make the diagnosis. I wish, right? But I sent him to another dermatologist, and it's the skin rash that showed Treponema pallidum, which is syphilis.
Yeah.
And basically, um, this patient had syphilis, and he had tertiary syphilis. The nerve were also involved, and he's been on treatment and is doing very well. And it's actually, when when I presented the diagnosis, basically to them, I said, well, the really good news is that this is curable. That means that you may never have joint pain again once we treat this. So that is kind of cool. Instead of rheumatoid arthritis or lupus, which then you have to kind of deal with this for a while. And Yeah, I think that I think that the it just tells us again that the intuition is so huge in medicine. And yes, it's because I've trained and I've 17 years of studying medicine and rheumatology. However, there was something I was like, because I remember their primary care physician was like, why don't you want to put this patient on biologic? And I was like, well, not yet. Something's off. Something's off. I don't want to, because they had synovitis, right? Which is like, per the criteria, we could have said they had rheumatoid arthritis. But yeah, so I think that's a good story. And to me, that's one of the reasons I'm a rheumatologist. It's just,
That's
this
fascinating.
exactly.
Fascinating.
And it's,
Well, then,
that's what we call the syphilis is the great mimicker.
the
Can
great pretender,
look
yes.
like
Yeah,
everything.
absolutely. Yeah, medicine is about incorporating multiple data points and building a story, which is why when um, the current crop of young doctors are a little bit too quick
Mhm.
to do away with the history and physical, There's so much you can learn from a physical exam, so much, and so much you can learn from a
Yeah.
careful history. First of all, letting the patient talk and then doing the directed questioning. I mean, that's how we were trained, and I still love it. And we were always told to do a full examination, including fundoscopy and a rectal exam. In fact, at our medical school, one of our teachers had the expression, if you don't put your finger in it, you'll put your foot in it.
Huh.
And, I mean, I'll trade with you of fascinating ones. There was a patient who came into the so-called emergency room, the A&E at one of the hospitals where I was working, uh, um, moribund, and had a cardiac dysrhythmia and had suffered from profound muscle weakness. An examination revealed mucus per rectum. And the patient, I got a phone call from the emergency room physician who said, got a patient here who's probably got a large villus adenoma and he's secreting potassium rich mucus. And he presented with collapse and cardiac dysrhythmia from a rectal lesion. How's
Wow.
about that one? That was a corker. That was
Yeah.
a very proud young A&E doctor. God bless him. So you've had an amazing career as a physician, an entrepreneur, and you've been a patient yourself. And I think that always affects one's perspective. Um, Tell us about what you think your proudest achievement would be, Isabel.
Oh, wow. I never thought of that. I don't know about what my proudest achievement is, actually, honestly.
Well, maybe it's unabridged. Maybe it's building a practice where you deliver the kind of medical care you actually want to deliver, right?
I feel like, well, yeah, I I feel that I'm not doing this practice just for myself. Actually, I really am not. Because I had it very easy. Like I was very well treated by my previous institution. They were wonderful. Um, it's that I love medicine so much. Love, love, love what I do so much. And I wish, and this is my goal in life, is to show other physicians what can be done, right? And show it with the outcome of my patients. My patients are doing better than I've ever done. So show it with the outcome of my patients. And because that's, from a dopamine release, that's what makes me the happiest on, daily basis. But the most important thing I think is to show other doctors what's possible. And even if they don't choose to do that as well, to basically say to the insurance, I'm not taking you, I'm directly paid by the patient, is to say that is a possibility. You can do that. So that, I don't know if it's what I'm proud of. I'm hoping that when I look back in, 50 years, that this what will be what I'm the most proud of. I don't know yet because I'm not there yet. Like I haven't seen other doctors do that and enter
Well,
this area.
that brings us to what will be my last question. I normally ask people about their wishes, but we've already done that with you. So, how's about this one? What would you say to doctors who are considering changing their clinical practice and thinking of adopting your approach?
Oh,
What would you say to them?
do it. Do it. Do it. It's basically what medicine used to be. Like when you're described the way you were trained, it's literally what I do now. And I'm just going full circle. We're just doing full circle into what we used to do. There is no reason to me that an insurance should decide how much we're paid, because we have responsibilities that are super high, right? And sometimes we want to be paid for this, sometimes we don't want to be paid. Like we decide. And so do it. The pleasure of practicing medicine is so high in this environment that I'm highly recommending this model. Also, to stop playing this game of cat and mouse where the physician is the mouse, and because in general physicians are good students, they say yes to everything, and it's time to say no.
Yeah, there's a disease, the disease to please. and it's something that people, especially doctors, should think about. And I'll throw one other thing out at you that I continue to do. I wasn't able to do it for every patient, but if and I was inspired to do it by a little old lady who had a cecal carcinoma who I'd done a right hemicolectomy on, and I wanted to see her back in the office, and she was not terribly mobile, so I paid her a home visit. I went to see her in her home. And I went at the end of the day, and it was a 5-minute consultation to check her wound, make sure she's doing okay. How is she? How is she mentally? She, made such a fuss of me. She had made tea and sandwiches, and I ended up sitting and chatting, and a couple of her friends and relatives were there. It was lovely. And
Yeah.
many, many years later, I have that memory, and I
Yes.
did that not as often as I wish I had, because I can tell you the thousands of patients I saw in the office. Do I remember those interactions? No. Do I remember the home visits? Hell yes.
Yeah.
So
And
I'm with you. I think
yeah.
you are a shining star. You are what medicine should look like. As you say, you've gone full circle. I'm afraid that's all we've got time for today. But just as last time, Dr. Isabelle Amigues, it was a real pleasure chatting with you. You keep doing what you're doing, girl, because you rock. Thank you so much.
Thank you so much.
So, folks, I can't believe that you wouldn't have enjoyed this conversation as much as I have. And if you're not already a subscriber, please become one. We're available on all the usual platforms. Like us, leave a review, blah, blah, blah. You know what to do. And check back in next week for another episode of the EMJ podcast. Until then, I'm your host, Dr. Jonathan Sackier. Thanks so much for joining. Please, everyone, stay safe, stay well, stay curious. Bye for now. Well, that concludes our 3-part series. Thank you for listening, and we'll see you soon in the next deep dive series.